Hello, everybody. We are live with Mikayla Dalton, one of the Premom virtual consultants. We're super excited to have you with us today, Mikayla.
Thanks, Terry.
We're going to be talking about trying to conceive and trying to avoid, but most of your questions are about trying to conceive, surprise, surprise. So we will be focusing in on that. But first, we'd like to get to know you a little bit, Mikayla. Can you tell us about yourself?
Okay, well, first of all, to explain the accent, I'm from Australia, but I've been living here in Boston, Massachusetts for 11 years now. 11 years, it's a long time. I have also been working in fertility awareness for about 9, almost 10 years now. So my time in the USA and my time in sort of reproductive area of work have kind of come together. So the two are inevitably linked for me now.
Nice.
Yeah.
Okay. And who do you tend to work with? What do you specialize in?
Let's see. I actually have a lot of postpartum clients. It's one area where a lot of people feel the need for some extra guidance. So I actually do end up with a lot of postpartum breastfeeding mamas who are looking for some help in figuring out where their fertility is. But it runs the gamut. I see people who are coming off birth control, wanting to move to a natural option. I see people who are trying to conceive. I work with people who are engaged and planning for the future. Already I work in all sorts of areas. It's really diverse and really fun.
That's really neat. Why did you decide to work with Premom?
Well, I had been looking for a solution to keeping track of my test sticks. So the fertility awareness-based method that I actually teach incorporates the use of various hormonal at-home urine tests. And I was looking for a solution to keeping track of them that didn't entail taping them onto pieces of paper in a row. And Premom has that wonderful app where you can take pictures of the test and they're aligned in a neat row and they're dated, and you can get the test to control line ratio, or Premom has its own really cool tests where they'll actually give you a numerical figure. And that was just game-changing for me. So then I hopped on board and bought the smart thermometer as well. And so I sync that every morning. So I've sort of really jumped into that. Yeah.
Wonderful. Yeah, I was poking around your info a bit and saw that you, I think, call yourself a femtech geek. Did I get that right?
Yeah. Yep. I am very into femtech. It's a little confusing out there. There are so many options. And it can be hard to choose what's right for somebody. But I'm very into modernizing the approach to suit people's lifestyles now. Yeah.
That's neat. Yeah, the industry has come a long way recently.
It has. Yeah, it sure has. My husband sometimes looks at me a little oddly when I come. It's with all of my gadgets. he's supportive, but he's like, I'm not sure. Is this normal? And I'm like, yeah.
Yeah, I saw your Borg reference. I loved that. That was awesome. Anybody who likes Star Trek, check out her. I don't know if it was Instagram. Be sure to check it out.
Yeah, that'll be on Insta. Yeah.
And I would love for you to talk a little bit about trying to conceive versus trying to avoid, particularly with tracking. I think trying to avoid is a little bit longer, right?
Yeah.
A little bit more complicated. So I'd love to hear your perspective on that.
It is. It's funny because sometimes you see people who've used fertility awareness to conceive successfully. And the idea is that you track your body's biomarkers, whichever ones you're using. So you have the hormone tests, like looking for the LH surge. You have cervical mucus, cervical fluid, if you prefer. You have basal body temperature. Those are the three main ones. There are some extras. And then you target the most fertile days to try for a baby.
Mm-hmm. And
so the fertile window technically is about 6 days. So you'll probably have 5 to 8 days where you're focusing your attention on making the baby. But when you're avoiding pregnancy, it's funny, it doesn't just work to flip it. So for achieving pregnancy, you're trying to target the very best days, and you have a fairly well-defined fertile window for the best days to get pregnant. But in avoiding pregnancy, every method is different. They'll all have different rules about what tools you're using and what approach you take for determining what days are potentially fertile. But you're looking for all potentially fertile days, not just the very best, most fertile days. So depending on the method, some methods might say that the days of bleeding at the start of your cycle aren't available, in the sense they're potentially fertile. So if you want to avoid pregnancy, you would not consider those days safe, because if you're relying on a biomarker like cervical mucus and bleeding is obscuring your observations, then you have to assume potential fertility. So you find that that window of days that are considered potentially fertile is different between trying to conceive and trying to avoid pregnancy. Because if you're trying to conceive, you're probably not trying on the second day of your cycle. But if you're trying to avoid, you might be like, well, this could be potentially fertile, so we should be aware of that. So it's a really different mindset, a different approach to fertility awareness, and a different mindset and different challenges. So both can be challenging in their own ways. And it's funny because you're using the same set of tools, but for different outcomes. And so it comes with a different set of challenges and set of approaches. Yeah.
And I know you talked about how you love myth busting. So that's pretty neat. That's a myth right there, right? The difference in trying to conceive and trying to avoid when you're tracking. It's not the same.
Yeah, I see it a lot. I've seen several people become unexpectedly pregnant because they tried to flip what they were doing for trying to conceive. And so we were trying to conceive, and so we had intercourse on these days to give us a good chance of having a baby. But now we're trying to avoid pregnancy, so we'll just avoid having intercourse on these days. But they weren't aware that you can't just flip it and expect good, like a level of effectiveness. And so there are some people who end up with a surprise baby when they were like, oh, why didn't this work? And just because I didn't realize that there is a difference. Yeah.
Right.
Yeah.
All right, fantastic. Let's dig into some of these questions. And I'm just peeking over my shoulder to see if we have any comments. It looks like I am able to see comments live. So if anybody wants to pop in with some questions as we're going here, please feel free. Keep in mind that we're focusing on more general questions. If you have a more specific question, save that for a consultation. You can find Mikayla right in the Premom app under schedule a consultation. But she's going to try to address as many questions as she can, the best she can right now.
I'll do my best.
Yes. Let's see. So first question is about LH surges. Why is my LH never showing surges, but I have regular cycles?
Oh, all right. There are potentially more than one answer. So one reason could be the time of day that you're testing. For some women, their LH surge is fairly short. So if you're testing just once a day, you may be missing it. Statistically, the best time to pick up that surge is somewhere between 10 a.m. and 4 p.m. Usually people say 10 to 2 or 12 to 2 or 10 to 4 gives a bit of a wider window. Statistically, that's where the surge is most often detected in the urine. And that's about 80% of women. However, you may not be in that percentage. So you might not see the surge in your urine until later in the day, for example. I know for myself, there was at least one cycle where my true positive and OPK, my true peak, was like 1 o'clock in the morning. Now, I'm a night owl, so my biorhythms may be a little different. So one thing you could try doing is testing at different times of the day. You may want to do multiple tests to see if you can pick it up. Do be wary of doing a first morning test, though. Sometimes first morning urine can be a little too concentrated and give you misleadingly strong results. So that's one possible reason. Another possible reason could be that perhaps you're not ovulating regularly, so you may be having bleeds on a fairly regular basis, but they may not be actually a menstrual period. In order to be a menstrual period, you do need to ovulate, and your uterus has to undergo these changes that occur due to the hormones specific to the luteal phase between ovulation and your next period. There are actually biological changes that happen there during to the hormones, and that bleed is a menstrual period. But you can have other bleeds, like hormonal breakthrough or withdrawal bleeds. So an estrogen breakthrough or estrogen withdrawal bleed. And sometimes women can confuse those for menstrual periods when they're not actually a real period. So that's another possibility that may be happening. If you can't find the LH surge and you've been testing it many different times, it might be worth seeing your physician just for a bit of a checkup.
Okay. Wow, I feel like that was a great answer right there. We could finish the interview. I'm really glad you addressed that, because that does come up. And I've done some work with customer service, and I know sometimes women will get, like you said, a good result at a different time than that recommended 10 to 4 window. And I say, go with what's working, because not everybody's the same. So that was a really helpful description.
Thanks.
Yeah, thank you. Someone asked what to do or eat during the 2-week window and what to avoid.
Okay. Well, in the approach that I teach, we take the basic approach that what's good for a healthy pregnancy is good for a woman in general. So the thing to do is try to maintain a healthy lifestyle. So you want to eat your fruits and your vegetables and get a decent amount of protein and healthy fats. There are a couple of things you may want to avoid during the 2-week wait or the 2-week window. One of those is non-steroidal anti-inflammatory drugs.
Oh, that's a big one.
So a common one is ibuprofen, but there are a range of them. The use of these has, in recent research, has been associated with more difficulties with implantation or early miscarriage. So you may want to avoid those non-steroidal anti-inflammatories. If you need some light over-the-counter pain relief, there are other options like aspirin, for example, that may be suitable for you. Definitely check with your pharmacist or your doctor about your best options for your body and your health history. But that's something to be aware of, because non-steroidal anti-inflammatory drugs are very commonly used over the counter. Pardon me. Another thing you may want to avoid is alcohol. I mean, this can be controversial. It's a very big part of our society. And I grew up in Australia, which has traditionally had a more relaxed approach to alcohol. However, it has also been implicated in lowering the success rate of implantation or increasing the rate of chemical pregnancies. So that might be something to kind of go light on or avoid completely at that time. But generally speaking, I think there can be a limited amount of things that we can do to control the process. So those are two of more recent ones that you may want to be aware of avoiding. Another thing you may want to do if this ever becomes an issue with you in successfully conceiving or carrying a child is to have a look at your progesterone levels. So if you have a history of repeated early miscarriages, you may want to look at your progesterone levels. And I know that Premom partners with Prove to include those tests in its app as well to make sure that your progesterone levels get high and stay high.
Yes. And we'll also be releasing some progesterone tests soon.
Oh, fantastic.
Very helpful. Yeah, very helpful double tracking system. Also kind of related to the voiding question,
Yeah.
can having oral sex or saliva near the vagina or on the penis while trying to conceive affect chances of conception?
Okay. Let's see. Well, the short answer is no. So you don't have to worry about that. When you're trying to conceive, typically you're having intercourse and the man ejaculates like fairly deep inside the woman, and so you're placing those sperm right up near the cervix, like giving them the best chance to get where they need to go. So saliva is not the most sperm friendly fluid. And this is normal. Sperm need like particular things that are good for them. Sperm need warmth and moisture and a certain level of a certain pH level. It's kind of alkaline. Usually the woman's vaginal canal is more of an acidic environment. It actually changes to become more alkaline as she becomes more fertile, which is friendly to the sperm. And the cervical mucus, cervical fluid that she's producing is actually becomes like nutritious for the sperm and protective. So the woman's body is actually cooperating very actively in the conception process. Saliva isn't the best for sperm, but it's not really a factor. If it's on the surface of the vagina, on the vulva, at the entrance, it's not really going to be affecting sperm that are deposited inside the vaginal canal. So I wouldn't worry about it.
Good to know. We have a question about the possibility of getting pregnant with ovary cysts.
Okay. Cysts on your ovaries are not that uncommon. It can happen randomly to women. So there's such a thing as a luteinized unruptured follicle, for example, that aren't that uncommon. If you have a lot of cysts, and you may have some other symptoms that might go along with the diagnosis of PCOS or polycystic ovary syndrome, that could impact your chances of conceiving successfully. Women with PCOS can have more trouble. It's not guaranteed that they will have more trouble. Plenty of them conceive with no problem. But that's definitely something. If you've been told that you have cysts on your ovaries, that's definitely something to ask your physician about. Go see your family doctor or your OBGYN and ask them, are these cysts on my ovaries, could they be a problem for conceiving? Like, do I have other symptoms that could indicate an issue? That's more of a medical question, and I want to stay out. That's not my area to answer. So it really depends on the context. Sometimes they can go along with issues that make it difficult to conceive, but it doesn't necessarily mean that.
Okay. And then I love this next question because, again, here's the myth part you were talking about. Is it truly beneficial to elevate legs after baby dancing?
Well, it can't hurt, but it's unlikely to help much either. So I was mentioning before that you're depositing the sperm right up in the vaginal canal close to the cervix. Now, sperm are held in seminal fluid. So when you stand up after intercourse, this may not happen straight away, but you will see seminal fluid come out of you, right? Or you will feel it. There are some sperm still in that fluid. They tend to be the ones that would probably be filtered out anyway as less robust. They're not all going to disappear. So they're not all going to come out with the seminal fluid because they move quickly. They're hardy little things. So if you're depositing sperm in the vaginal canal close to the cervix, what they start doing is they start swimming, like in their special little corkscrew fashion, just wildly swimming for their lives, and they'll be trying to make their way to the cervix, which has special little crypts that harbor them, basically. So it provides a safe place for them to rest, get some nutrition, fortify themselves for the journey. They're not going to fall out of you with the seminal fluid. there's nothing you can do to stop them. So like if you were to have intercourse and then immediately stand up and jump up and down trying to get it out, that doesn't work, right? Because they're tiny little things already on their way. So likewise, trying to encourage them by holding the seminal fluid in is unlikely to do anything much. You really don't have to do it. It makes some women feel better about it, like they're doing something, and it can't hurt. So if you want to, you can lie there with your legs in the air. And if you're okay with that, by all means, go for it. I wouldn't do it. I think I'd start to feel a little ridiculous if I tried. But, it's not, as best as we can tell, it doesn't actually improve any chances statistically.
Okay. How about CrossFit? Does CrossFit, HIIT exercise affect implantation or trying to conceive?
Okay. Similarly to how I was just talking about, if you're trying to avoid pregnancy, jumping up and down immediately after sex to get the sperm out isn't going to work. It's similar to that for implantation. I mean, this is happening at a cellular level. You can't dislodge the cells by intensive exercise. There's no amount of burpees that you can do that is going to affect implantation. So, feel free to do your exercise. However, if you're doing very intensive exercise, like high intensity interval training, CrossFit, that can have an effect on your fertility in general. So maybe not implantation specific, like you were asking, but in general, very intensive exercise. This happens with professional athletes, people training for marathons. It can cause menstrual cycle irregularities. It can stop you ovulating. So if you go from a sedentary lifestyle and then suddenly start a really intensive exercise, it can kind of throw your body into a sort of shock, and that might mess with your cycles. But also, if you're consistently exercising to a very high level, your body may be doing a version of conserving energy, where it's like, this is not a good time to get pregnant because like this person is either has a very low body fat percentage or is stressing their body in a certain way. And it could be healthy in one sense, but it could be unhealthy reproductively. So that's something to be aware of. If you're trying to conceive and you feel like your cycles are a bit messy and you may not be ovulating, you may want to ease back on the exercise a little.
Okay. Then we had a question about, this may be a little more specific, but they have a regular period, they're getting positive OPKs, they have egg white cervical mucus, so they're doing all the tracking.
Good stuff.
Right, but they're still not pregnant after a miscarriage at the beginning of the year. So like, any thoughts on that?
Oh yeah, I'm so sorry. So that is because you're checking with the LH tests and you're following your cervical mucus and you're tracking your cycles. It's important to know what is the normal range of conceiving. So for people who are charting fertility, who have healthy fertility, these are the trying to conceive success rates over the cycles. So in the first cycle of trying, in one study that was published in 2003, the success rate was 42%. In the second cycle of trying, that success rate went up to 50%. It was up to 75% in the third cycle. And then in cycle 6, it went up to 88% had succeeded. And this is in a group of women couples with healthy fertility. That 88% by the conclusion of the 6th cycle is roughly equivalent to the success rate that people who are not charting at all and timing intercourse achieve after a year of trying. Okay, so if you have been charting for more than those 6 cycles, and I'll avoid January, February, because coming after a miscarriage, your hormonal profile may not be ideal. But if it's been more than 6 cycles without success, at that point, I would recommend for my own clients that they seek medical advice, because if they've been charting and timing intercourse and 6 regular cycles have gone by without success, they're in the same position that another couple who are not charting and timing intercourse would be after a year. So it sounds like it may have been more than 6 cycles for this person. So I don't know the reason why she may not be conceiving, and there are a whole swath of reasons. It could be her, it could be her partner, it could be a hormonal issue, it could be anything else. But yeah, it sounds like she's been diligently tracking, and if it's been 6 cycles with no success, then she knows she's in the 12% who haven't, and at that point it's worth taking a look and seeing if something's going on. Yeah.
Okay. And then we have a question about molar pregnancy. What are some things to help get pregnant after a partial molar pregnancy? There was a termination at 20 weeks, also a chemical last month, working with letrozole. Any thoughts?
Okay, well, that's really tough, and I'm so sorry for this questioner. That's a very sad situation to be in. For anyone who's joining us or watching afterwards and who doesn't know what a molar pregnancy is, it's been described as a genetic accident, which is not a term that I like, but it gets to the idea that with a molar pregnancy, there are 2 types, complete and partial. And with a complete molar pregnancy, what happens is you have an egg and sperm that meet, and somehow the woman usually provides her chromosomes, 23 chromosomes in her egg, and then the man provides 23 chromosomes with his sperm. And they join together and make a new person with their own genetic makeup and 46 chromosomes. But what happens in a complete molar pregnancy is the woman's chromosomes are missing somehow, and the egg gets 2 sets of the father's chromosomes. This affects the placental cells. They don't develop properly into a properly functioning placenta, and the baby will never develop at all. There's no baby there because it doesn't have the mother's chromosomes that it needs. In a partial molar pregnancy, which is what this questioner had, the mother's chromosomes are there, but she gets 2 sets of the father's chromosomes, typically because 2 sperm managed to get in there instead of just the 1. This again causes problems with the placental cells development and the development of the baby itself. It's very chromosomally abnormal, and it doesn't usually survive. So this happening seems at this point to be relatively random. Molar pregnancies are more common in very young women, like in the early teens, and in women over the age of 40. So there's a higher risk. Molar pregnancies that are complete are about 1 in 1,000, and it's even more rare for partial molar pregnancies. So I don't know that there's anything you can do to prevent that from happening, because it's just a deviation from the normal conception process that happens when the sperm is meeting the egg. You can't really control that. Chemical pregnancies, there can be a variety of reasons for that. A chemical pregnancy is when the sperm and the egg meet and they implant, so they join, and then you have implantation, and it may be just enough for a pregnancy test to pick up as positive, but it's a transient positive. Miscarriage happens very soon after. In most cases, if women aren't tracking, it just will seem like a regular pregnancy. They're very, very, very short-lived pregnancies. Regular period. So they're very short-lived pregnancies, I just realized. So we think that most of the time with chemical pregnancies, again, that it's a genetic or chromosomal issue. although there are many reasons for early miscarriage. So one thing you could try doing is there are various diets out there that are supposed to help you nurture your eggs. So all of the eggs in your ovaries are in a kind of primordial state. You have all the eggs in your ovaries, like in your ovaries when you are in your mother's womb, right? So they're there already, but they can't be fertilized. They have to go through a maturation process before they can be released and fertilized. And this process actually takes a long time. It actually takes months. Interestingly enough, there's a very slow process. So there are some diets out there that are aimed towards helping develop a healthy egg batch that you could look at. You could look at other reasons for early miscarriage. If you have repeated early miscarriages, it's worth seeing your doctor. Again, there's a progesterone issue that could be there, but there's a whole range of other things like mild inflammation in the uterus. Some people look at MTHFR mutations. There's a whole range of things that the medical profession will know about. So you can look at that. But unfortunately, with molar pregnancies, there's very little that we can do. The reproduction is still, we know a lot more about it than we used to, but it's still very much a mystery in some senses. And when things go wrong, we don't always know why. Yeah.
Excuse me, I'm going to throw a plug in there too, since you're talking about miscarriage. We are going to have a panel this Friday focusing on that topic specifically. So if there are further questions about chemical pregnancies, miscarriage, anything of that nature, I'll be putting an announcement in soon, so keep an eye out on that to register for that webinar. Little plug thing. I think we did get some live questions. Maybe just one. Somebody did ask if this is being recorded, and yes, it is. So I don't know if it'll be recorded to this Facebook group because we're doing it through Zoom, but we do also record it to YouTube and share that there also. Make sure you subscribe to our channel. Let's see. Someone is wondering about her chances when her AMH is only 2.7 and she's 40. She's thinking about IVF. I know it's getting specific, but just any general thoughts.
That's very specific.
Yeah.
AMH is just one indicator. That's what I want to say. It's just one indicator. There are some questions about how useful of an indicator it is, chances of conceiving. The age that women go into menopause varies a lot. So anything between something like, off the top of my head, I think it was 35 to 60, but usually the average age hovers around about 51. And usually by 55, women are no longer fertile, like the vast majority of women. I know that fertility does decline. And a lot of people say 35, but it does not drop off a cliff at the age of 35. So like a lot of women are panicking unnecessarily when they hit 35, but it doesn't drop off a cliff. There's a slow decrease, very slow. Once you get over the age of 40, that decrease is much more noticeable. So if you wanted to try for a baby, then seize the day. I can't speak to IVF. That is outside my purview. So I can't say. I know that IVF success statistics, especially for older women, like over the age of 40, are not great. So it would be a consideration as to whether you wanted to pursue that route or whether you wanted to pursue a more natural route, like as intensively as possible. So there are functional medicine doctors, there are reproductive endocrinologists, there are the NAPRO physicians. There are a whole heap of people that would be thrilled to try to help with the natural conception. And depending on your circumstances, that can be as effective or more effective than IVF. So it's definitely something to investigate. But you'll need to really receive personalized advice on where your body is at. Yeah.
All right. Fantastic. And I think that was about it. Thank you, everybody, for all of your questions. Amazing. And thank you for your very thorough answers, Mikayla.
Oh, you're very welcome. This was a great selection of questions. It really kept me on my toes.
And you did great. And if you would like to meet personally with Mikayla to go over your charts, any further or personalized questions you have, again, you can find her right in the Premom app. If you go into, I think it's still in the More section, you schedule a consultation, you can find her under Fertility Awareness Method Professionals, right? And go from there. So thank you again, Mikayla.
You're very welcome, Terry. My pleasure.
And hopefully we'll have you on again soon.
I'd love to. Thank you so much.
All right, take care. Thank you, everyone.
Bye.